I'd like to call back Professor Mick Kumwenda to share with us some updates about the recent trials in the management of type 2 diabetes. Welcome once more.
Thank you very much, Mr. Chairperson. So, yes, I have to make sure I finish on time, if earlier possible, for prayer time to take place. So, update in the type 2 diabetes trials. And 20 minutes, we obviously cannot cover everything. As you've heard, 1.8 million papers written every year. It's almost impossible to cover this in 20 minutes. Majority of these studies you've already heard through the Congress. So the idea is just to summarize some of those and take out some of the key points that are being shared in most of the other studies that we've heard about. A lot of them, I'm going to talk about cardiovascular outcome trials, and also which will include glycemic control, cardiovascular disease control, and lipid management. Those are the ones that I've selected. So we've had quite a huge publications come out since 2008, when the FDA issued guidance on pharmaceutical industries to setting new expectations of development of anti-diabetic drugs for type 2 diabetes. They mandated that long-term cardiovascular outcome trials are done mainly for safety, at least to show non-inferiority compared to previous studies. And so far, in type 2 diabetes, 9 have been reported, and none of those have shown any inferiority. And there are 4 that have been shown to have benefit on patients in terms of reduction of cardiovascular deaths. And this is LEADER, SUSTAIN 6, EMPA-REG outcome study, and CANVAS study. 2 have reported reduction in all-cause mortality, which is LEADER and EMPA-REG. 13 are still underway. 4 were terminated because of adverse events, and so far we've had 190,000 patients recruited in these trials so far. And this is a cartoon just to show what's been done, completed, and what is still ongoing. So you can see half of them are actually due to be published towards the end of this year, and going on to 2020. So there's a lot that we're going to hear from these trials over the next few years. I've selected a couple of these. The slight difference in design of the studies, which has actually impacted on the outcomes. And one of these is the EMPA-REG outcome using empagliflozin. And this was published in 2015. There were 3 arms, so there's a placebo arm, there's a 10 milligram arm, and a 25 milligram arm. This is giving patients this agent in addition to standard care. And the primary outcome was 3-point major adverse cardiovascular events, and then analysis, pooled analysis of the empagliflozin group compared to placebo. And the key elements were that the patients had type 2 diabetes with established cardiovascular disease. And there's a slight difference with the next one, which I'll talk about, but this is what was the main difference. They recruited more patients who had events. Patients had HbA1c between 7 to 10%, eGFR of more than 30 mils per minute. And the other one, which is CANVAS, again, using canagliflozin, 5,795 patients in the intervention arm and 4,347 in the placebo arm. Again, patients had HbA1c between 7 to 10%, eGFR was similar to the other one. But the difference was there's a history of prior CV event in this group of patients. And you can see the differences so the mean ages were similar, HbA1c was similar, but the EMPA had more patients with cardiovascular risk, compared to CANVAS. There was more patients with hypertension in CANVAS, and there was more patients with heart failure in CANVAS. And this recruitment may have impacted on the findings. So if we look at EMPA, we'll see that there was a 38% reduction in cardiovascular deaths, which was significant, and 32% reduction in all-cause mortality, again, which is significant. 35% reduction in heart failure-related hospitalization. And CANVAS, you can see there was less achievements, and I think there was a difference, if you recall, that there was more patients with cardiovascular events in the EMPA. So if you take the high risk factors, patients in that group will show more benefit than if you take less risk factor patients. So 13% reduction in cardiovascular death, 32% reduction in deaths or heart failure related to hospitalization, and 13% reduction in all-cause mortality. What was interesting is this separation of the graphs in the EMPA group occurring within a few weeks of starting the trial. And you can see incredible difference between placebo and treatment with empagliflozin over the next few months. So obviously this is not just glycemic control. There must be something else that is controlled, that is operating to impact on the mortality of the treatment arms. And some of the potential mechanism for benefit has been highlighted already, and this is to do with osmotic diuresis with SGLT2 inhibitors, glucose and sodium removal, and there was also some reduction in blood pressure, and in some of the study on canagliflozin, there was attenuation in the production of BNP. And there is obviously, when you've impacted on these three elements, there will be a reduction in the pre and after load, probably a reduction in the incidence of arrhythmias and improvement of myocardial performance, and therefore the outcomes will obviously come up as positive in the reduction of mortality, hospitalization due to heart failure over time. There were some safety issues. Usually drugs that work very well have also got their own problems. And there was, what was interesting, they didn't see a significant increase in urinary tract infection, ketoacidosis, or acute kidney injury in these two trials, although this problem has been reported with other agents in the same family. There was a significant increase in the risk of amputation in CANVAS, and the explanation for that is unclear, whether that was a predisposition to diabetes foot care, we are not quite certain. The FDA have strengthened the existing warning that there is a risk of acute kidney injury in these agents, and that may be related to dehydration because of the excessive diuresis, and that we must always inform the patients to have a adequate fluid intake. There is also an association of a small reduction in eGFR, particularly at the beginning of the treatment with SGLT2 inhibitors. Fortunately, this reduction in eGFR tends to improve over time. So if you see a 5-10% reduction, it doesn't mean you should stop the agent. You should give it a chance for the eGFR to recover. So is this a class effect? Are we confident that these drugs will be the same for all patients at all times? And obviously the answer is possibly not. I want to draw your attention to this increased incidence in the heart failure patients with the trial using saxagliptin. There was a hospitalization, significant incidence of heart failure due to hospitalization in that study. What about combination therapy of the HGLT2 inhibitors and the DPP4 inhibitors? And this is a systematic review that's come out, and basically is comparing the efficacy and safety between combination therapy of the two versus DPP4 inhibitor on its own and placebo. In patients with type 2 diabetes, with primary outcome changes of HbA1c, fasting glucose, 2-hour postprandial glucose, body weight. 7 eligible RCTs were identified, with around about 2,000 patients were included in these comparisons. Hypoglycemia was more significant in the combination of SGLT2 inhibitor and DPP4 compared to placebo and DPP4 on its own. There was a risk of increased urinary tract infection in the DPP4, but not in the combination group. And of course, the risk of genital infections, which has been reported in most of these trials, was also seen, particularly if HGLT2 inhibitor was added on to DPP4 rather than when it was started as in combination therapy. So there's several combination therapy trials that have come out so far, and these were the ones that were included in the meta-analysis, so round about 7 trials altogether, but we probably don't have time to go through all of these. But when you look at the meta-analysis, and what they've done here is to combine all those elements, the primary endpoint outcomes that I described earlier, and there was obviously a benefit when patients were treated with combination therapy compared to DPP4 on its own. If you look at each specific element on its own, and if you look at the fasting blood glucose, and again you can see there was a better outcome in the combination therapy compared to DPP4 and placebo. If you look at the relative risk of achieving HbA1c below 7%, again, the combination therapy did better than DPP4 and placebo. And the change in weight, again, you can see there was better results in the combination therapy compared to DPP4 and placebo, showing a very powerful synergistic effect when we combine the two in the same patients. So we just move on now to lipid-lowering agents in type 2 diabetes. As you know, that again, achieving targets in lipid management is still poor throughout the decade that we've had statins on the market. And you can see, although there's been an improvement compared to the 1900s, compared to 2007 to 2010, we are still only achieving the targets in under 60% of our patients. So these drugs have now come out on the market, and just to show the mechanism of the PCSK9 inhibitors, LDL cholesterol does impact on statin lowering by interaction with the LDL receptor on the endothelium. The LDL cholesterol then on this receptor induces mechanisms to take up the LDL cholesterol into the cell. The PCSK9 inhibitors block the receptor and therefore prevent the uptake of LDL cholesterol into the cell. This is the data from the Odyssey trial. These were patients given alirocumab and evolocumab. Both of these are PCSK9 inhibitors. And you can see in the Odyssey trial, 441 patients were recruited. These are patients, both type 1 and type 2, treated with insulin. And you can see after 24 weeks, there was a LDL percent reduction of 48% compared to placebo. Similar results were found with evolocumab. Again, percentage of patients achieving higher levels of target were higher in the intervention group compared to placebo. So I think what I've done is to just give you a flavor of the trials that have made a major impact in terms of not only glycemic control, but also in cardiovascular protection. And then we've also gone through some of the 2 trials that have shown that we can actually improve cholesterol management by the addition of PCSK9 inhibitors, which are now on the market, although expensive, but at least there's hope there that in some of these patients with very high levels of cholesterol, we can actually give them something that might work a bit better. So in terms of saving time, I've just given you a flavor of what's going on in terms of type 2 management, so that it's not just glycemic control, but we've got tools to actually control the cardiovascular risk factors in a better fashion than what we are doing at the moment. So, ladies and gentlemen, thank you very much for your attention. I stop there.